Hello, my name is Vivian Fonseca. I'm a professor of medicine and pharmacology, the Tullis-Tulane Alumni Chair in Diabetes, and the chief of the section of endocrinology at Tulane University Health Sciences Center in New Orleans, Louisiana. Welcome to this interactive exchange program. Our goal today is to discuss what we know about the incretin hormones, including how we can take advantage of incretin signaling to reduce hyperglycemia and potentially improve other clinical parameters in patients with type 2 diabetes. Incretins are gastrointestinal peptide hormones that stimulate insulin production and secretion from pancreatic beta cells in response to food intake. They also regulate the pancreatic alpha cell, suppressing glucagon secretion following a meal. Their existence was first hypothesized based on the observation that higher levels of insulin are secreted when glucose is administered orally as opposed to intravenously, even when the final plasma glucose concentrations are equivalent. More recent scientific and clinical research has shown that these peptides regulate a wide range of physiological processes, including the secretion of other hormones from pancreatic islet cells, lipid metabolism, gut motility, appetite, neuronal survival, and various functions of the immune system. For example, let's take a look at how the incretin system helps control postprandial blood glucose levels. After we consume food, increased luminal levels of carbohydrates, fats, and proteins rapidly induce the release of various peptide hormones and signaling factors into the bloodstream from enteroendocrine cells further along the gut. Two of these hormones, glucose-dependent insulinotropic polypeptide or GIP and glucagon-like peptide 1 or GLP-1, have been shown to stimulate insulin release from the pancreas. GIP is released from K cells, which are predominantly located in the proximal small intestine, whereas GLP-1 is produced by L cells, which are primarily found in the distal small intestine and colon. GIP and GLP-1 travel through the bloodstream to the pancreas. In the presence of glucose, these hormones bind to a G-protein coupled receptor on beta cells, resulting in enhanced insulin biosynthesis and secretion. In healthy individuals, incretin hormones may be responsible for between 50 and 70% of the insulin released after a meal, although this point is still a matter of some debate. The increased levels of insulin enhance glucose uptake by the liver, skeletal muscle, and fat tissue, and lower the concentration of circulating glucose. GLP-1 also inhibits the release of glucagon from pancreatic alpha cells. Lower plasma glucagon levels signal the liver to decrease the creation of glucose by glycogenolysis, further normalizing postprandial spikes in blood glucose levels. Because this effect is glucose dependent, reductions in blood glucose after the ingested nutrients are cleared will restore glucagon release and hepatic glucose production, thereby reducing the risk of hypoglycemia. The incretin system also regulates gastric emptying, intestinal motility, and satiety. For example, preclinical and clinical data suggest that high plasma concentrations of GLP-1 inhibit the contraction of intestinal circular muscle, which plays a dominant role in churning and moving nutrients through the small intestine. GLP-1 also binds to GLP-1 receptors on vagal primary afferent fibers in the gut. The activated neurons transmit signals from the gut to the brain, which relays the information back to various muscles of the stomach, reducing the speed at which nutrients pass out of the stomach and into the small intestine. This process helps spread out the intestinal absorption of carbohydrates, fats, and proteins over time, further blunting the size of postprandial spikes in blood glucose levels. GLP-1 induced activity in the vagal afferents also contributes to the feeling of fullness and reduced appetite following a meal. Although most of the incretin hormones produced in the gut are rapidly degraded by the enzyme dipeptidyl peptidase 4 or DPP4, some GLP-1 may reach its receptors in the area of the central nervous system involved in satiety. Moreover, some neurons in the brain express GLP-1, which may contribute to local pathways in the central nervous system that help induce satiety and indirectly decrease food intake. Clinically, GLP-1 analogs that are used to treat patients with type 2 diabetes have been designed to resist DPP-4 cleavage. Therefore, when supraphysiologic doses are given therapeutically, these analogs likely stimulate both central and peripheral GLP-1 signaling pathways involved in satiety. Indeed, all the GLP-1 receptor agonists that have been shown to produce significant weight loss in clinical trials. A decrease in the incretin effect appears to be a specific and early manifestation of the development of type 2 diabetes. The underlying mechanisms are likely multifactorial. Deficient incretin-induced islet cell responses have been observed very early in the disease course as glucose metabolism becomes impaired before other signs of beta cell dysfunction are apparent. Some evidence also suggests that GLP-1 secretion after a meal is impaired in type 2 diabetes, whereas glucose-induced insulin responses to high levels of exogenous GLP-1 remain. Research into the details of these effects is ongoing. Now that we have reviewed some of the functions of the incretin hormones, we're going to discuss various case studies that illustrate the potential roles of incretin-based therapies in the management of type 2 diabetes. Thank you for your time and enjoy the rest of the program.